Hello, everyone, and welcome to this webinar highlighting one of the many behavioral health treatment program models that we have here in Virginia. My name is Nelson Smith. I'm the Commissioner of the Virginia Department of Behavioral Health and Developmental Services, and I want to thank VHHA for hosting this event and inviting me to participate. In a few moments, you're going to hear about the Carilion Clinic and their comprehensive psychiatric emergency program during the webinar presentation. But before that, I want to take an opportunity to tell you about our vision and direction here at this agency. Our shared mission is to strengthen the behavioral health system in order to better serve Virginians, their patients, and their families. Our system has a lot of stakeholders. This agency, the community service boards, the patients, the community-based providers, families, advocates, law enforcement, so many. But every one of the roles are different, and each one of them is incredibly important on how we impact this system to support our families and, again, our patients. In order to enhance our system, it's going to require innovation, which will incorporate public and private sector investments, and continued collaboration in order to identify these opportunities for improvement and to develop better strategies and also execute on those. Here at DBHDS, we have a very, very broad mission that affects hundreds of thousands of people with behavioral health disorders and developmental disabilities and their families throughout the Commonwealth. We're committed to ensuring that we have consistent access to quality and care no matter where they live. But in order to do this, we're going to focus on strengthening our workforce, expanding the continuum of care, and modernizing our systems and processes. In doing so, it's going to have a tremendous impact on the delivery of our quality services from inpatient to outpatient, early intervention, intensive services, and people seeking mental health and substance use disorders, also developmental disabilities. We're going to be working to ensure that we have the staff to do it and making sure that it's easier to do business in Virginia. It's part of supporting our strategically developed services in our private sectors. The work we do here together is going to guide the much needed improvements, to transform our system so that Virginians can thrive in their communities. So I want to thank you for your partnership, your interest, and commitment to being part of the solution for enhancing Virginia's behavioral health care system. And so now, as they say, on with the show.
Good afternoon, everyone, and thank you so much for joining us for today's webinar. My name is Jennifer Wicker, and I serve as the Senior Director of Policy and Government Affairs for the Virginia Hospital and Healthcare Association. I would like to give a special thank you to Commissioner Nelson Smith for his introduction and ongoing partnership between DBHDS and behavioral health stakeholders and advocates. As we highlighted during our last webinar, there are so many individuals and organizations who share a passion for improving access to care and treatment for patients and families in need across the Commonwealth. This webinar series allows us to underscore the importance of partnerships and collaboration, as well as open communication to take advantage of the opportunities that exist to work together and help solve system-wide challenges. As we all know, no one part of the system can effectively impact change alone. As a reminder, over the course of this webinar series, we will place a spotlight on innovative hospital programs that were established with some funding assistance from DBHDS and the state legislature and have resulted in improved patient outcomes. Joining us for today's installment are two members of the Carilion Clinic team. We have Dr. Anilla Del Fabbro, the System Director for Emergency Psychiatry, and Ms. Lisa Dishner, Senior Director of Nursing for the Department of Psychiatry and Behavioral Medicine. Over the next 30 minutes, we'll discuss their work and the positive results of Carilion's Comprehensive Psychiatric Emergency Program, or CPEP, which offers more treatment options to patients in their own communities and has helped to reduce the number of involuntary patient transfers to state psychiatric hospitals which is especially important given the bed availability challenges that exist across the system. So welcome to you both.
Thank you so much. I'm very excited to be here. I'm passionate about our work in the emergency room and very grateful to be DBHDS for the funding and the help.
Absolutely, absolutely. Well, let's go ahead and begin our conversation about Carilion's Comprehensive Psychiatric Emergency Program, which you all began in 2020 with support from DBHDS, as was mentioned. The hospital-based emergency psychiatric program helps patients in a behavioral health crisis. It's 24 hours a day, and it has support from a multidisciplinary team of emergency medicine providers, psychiatrists, social workers, licensed professional counselors, and peers. Please tell us about the program's origins and how it functions in terms of intake and evaluation.
Absolutely. This is a program that is really based on or modeled after the New York State Office of Mental Health program designed for psychiatric emergency medicine. It really is embedded at Carilion within the ED. It's a psychiatric team that consists of a number of folks, and I'm going to hand it over to Lisa in just a minute here. But really what we're trying to do is, first of all, make sure there's no medical issues with the individuals that contribute to their mental illness. We want to rapidly stabilize them in that acute crisis. We want to avoid any coercion, any restraints, anything physical, if at all possible. And we want to treat them in the least restrictive means while forming a therapeutic alliance with our patients. And during that, we want to start right from the get-go in making an appropriate disposition and aftercare plan. So Lisa's going to tell you a little more about how we go about doing that.
Thank you, Dr. Del Fabbro. So our patients will come to our emergency departments across the system for management of their illness. And when it has been determined that the patients need treatment for their substance use or psychiatric illness, our clinical team, which was mentioned that is multidisciplinary, will work collaboratively with the patient to determine the patient's treatment plan. Those options include many aspects of care. So we have the comprehensive psychiatric evaluation with treatment planning and initiation of medication management. We have social work assessments, cognitive and behavioral skills and education for our patients, safety planning for discharge, access to our individual and group therapies, which includes adjunctive therapies such as our rec therapy and music therapy partners from our system. We also initiate the Start Now program so that we can meet the needs of our patients in the emergency department. Our team will then refer patients back to their communities for resources or inpatient psychiatric care at Carilion or other facilities when necessary for their treatment.
Wonderful. It sounds like an amazing program and a lot of services and treatments that you're trying to pack in a very short amount of time. But it's absolutely necessary, as you said, to get people stabilized as quickly as possible and start treatment and get them to the most appropriate level of care. So a moment ago, you mentioned that one of the goals of this program is to help reduce involuntary patient transfers to state psychiatric hospitals. Since the inception of the CPAP program, what have the positive results been in terms of redirecting patients who might otherwise have been sent to a state psychiatric hospital?
Yeah, this is a very exciting component of the program, I will say that, because a lot of folks we know can be stabilized in the first 24 hours. A lot of them come in with substance use or things that could really resolve within that amount of time. So the program has redirected 220 patients away from the state psychiatric facilities over a 7-month period. The redirections are not only to outpatient facilities or programs, but also to CRMH or other local inpatient units. And also we have one of our social workers working very hard to get our geriatric patients back to their skilled facilities. Primarily, the primary diagnosis is serious psychiatric illness. There are many others, but we try just to capture that component. It's about 76%. Substance use is much higher than reflected in our data. It says 9.35%, but we get a lot of folks who have dual diagnoses, and we do have peer support seeing them and helping them get to a place other than the state hospital. We have pediatric patients, and we know that the geriatric patients, at least anybody over 45 years old, and then the pediatric patients are the ones that are going to board for the longest in the ED. And so we really target those folk, as well as developmental disabilities and autism spectrum disorder. I'm a child and adolescent psychiatrist as well, so that is my passion, as well as a recent program to kind of get our perinatal patients quickly through the ED and concierge them to the next place, which is usually outpatient and back with their little ones. We also developed, thank you to DBHDS, a gap care clinic, which is gaining access to psychiatric care. And it's really bridging that gap between being seen in the ED and before you see your long-term permanent psychiatric provider, whether it's a PCP or a psychiatrist, and we see folks for 3 months or 3 visits. And that has been going really well in kind of allowing another option, as well as all the other community service board options, such as crisis care. But it's another avenue where folks feel, I've started on meds, I'm doing well, I can see a psychiatrist quickly, and we also get them into counseling. So I hope that helps.
Yes, that's very helpful. Lisa, did you want to add anything to that, or has Dr. Del Fabbro covered it all? Oh, I believe you're muted.
You'd think we'd have that figured out. So I believe Dr. Del Fabbro covered most of that. I think there is benefit to our gap care clinic and getting folks out of our emergency departments quicker and getting them connected to services.
So I'm curious, in terms of the community-based services, and we know that there are multiple challenges around workforce and things like that. Are there any particular gaps that you're seeing in being able to transition people to that next level of care? So if we have stakeholders that are listening to this conversation, is there a place where we're particularly having difficulty making those connections?
I think every place I've worked in across the country and across the world have a lot of gaps and not enough services for psychiatric patients. I think that DBT is very important. We have that at Blue Ridge and I think perhaps Piedmont, but that's extremely important. I think multisystemic therapy would be very helpful. I think IOPs and partial hospitalizations would be very helpful as well. I think we know that residential for kids and adolescents may not be the best thing, but I think getting both kids, adults, and geriatric patients back into the community with their loved ones would be important. I could go on for a long time, so I'll write a list and send it to everybody.
No, I appreciate that. And I appreciate your passion, Dr. Del Fabbro. So, hearing the initial results of this program, it seems that this model could be replicated in other parts of Virginia. So what are your thoughts about that? And can you kind of talk about some of the challenges that you may have experienced in getting the program up and running for anyone that may be thinking about doing something similar as the work that you guys are doing in Carilion?
Yeah, I think this is a wonderful opportunity, and I think that a combination of working, partnerships with the public-private sector are amazing. We're not the only program. There is the MPACT program out of Lynchburg with our colleagues over there at Centra that I'm very excited about. We had an NP who worked for us and is working there now, so we're working together. And then a crisis receiving center is another model. I think all these models are really looking at destigmatizing psychiatric care and mental health. And I think that goes a long way. We want to treat people with dignity. I think we have a large faction of our folks that come from, the rescue mission. I think beefing up or helping with that as Carilion is, and, all the stakeholders are, I think is very helpful. I think, Lisa, the other thing I want to mention is the issue I've come across is that according to Virginia code with the TDO, a physician or a psychologist is able to lift their TDO, and working with the community service boards has been very helpful, working with law enforcement. They've been amazing. And I think it's just building those relationships as with everything, and communicating really well. That would be helpful. Lisa, do you have other things to add?
I do agree with you that the communication and the collaboration and partnerships with our communities are key to our success. Our patients, of course, the goal is to connect them back into our communities, and pulling them in and leading into their resources is very helpful and beneficial to our patients' outcomes.
So I'm glad that you all touched on the communication and collaboration. As we all know, there are 5 different regions, behavioral health regions throughout the Commonwealth, and there are some parts of the state that I have found do an excellent job in terms of that communication and collaboration, and there are other parts of the states that are struggling just a little bit. And so again, seeing that you all have had the success within your region, can you talk to us a little bit about how you've been able to make those collaborations work, and be able to successfully connect people to services with the community services boards, and to help alleviate some of the strain on law enforcement? Can you just speak about that partnership and that collaboration that you're seeing in your region?
Yeah, and I think Lisa will have more context and history than I do. I've been here for 2.5 years, but I do think that we have meetings. We have a points of care meeting. We have a regional utilization meeting every month. And I think within Carilion, at least at CRMH, I do see folks at all the outlying Carilion facilities too via telemedicine. But at CRMH, we really work hard with nursing and with law enforcement at Carilion. And I think building those relationships has been key. Lisa, you've been here for longer. What thoughts? I think
it goes back to us being active in the community. So partnering with our community partners, getting on those meetings and advocating, hearing what their struggles are, and sharing the same. We try to be very transparent and open when we have those dialogues. So when challenges arise, we have that relationship built so we can really reach out and try to navigate through some of those complex situations together.
Yeah, and we do, Dr. Northwell at Catawba is very communicative. I think the other piece that I've been incredibly impressed with is that our ED physicians are getting really used to the idea of having psychiatry in there. And so just that communication within the institution, I think, is very helpful. Blue Ridge has been great. They had, one of their, we meet with them monthly, but they also had one of their providers come over and really get in there and try to help the folks that they see consistently.
Gotcha. So you talked about the statistics and the success that you've seen with the CPAC program in terms of the initial goal of diverting individuals from state psychiatric hospitals. Would it be possible to kind of key in really into some of the strategies that have been most successful with the program being able to exceed expectations in terms of the diversion. So what have been some of those key points that have worked extremely well that other folks may be able to replicate and do within their programs if they don't do the full-blown CPAT program, but maybe they can do a part of what you're doing?
So some of what our care team coordinates and works with our patients on once they're in the CPAP program is that ongoing collaboration with our patient, connecting them back to their home communities. So really getting that collateral information, reaching out to the communities to see what resources are available for our patients so that we can avoid those unnecessary hospital admissions when possible. Our program offers a spectrum of medical and mental health treatment options. So we have our ED providers, our psychiatrists, our social workers, nurses, psych techs, and various adjunctive therapies to come in and treat our patients in a very safe, but the least restrictive environment possible. Trying to equip them rapidly with the skills needed to be successful back into the community as well. We do have the option to, of course, to admit our patients to our inpatient psych units when needed. We also can place and work to place patients at other facilities. And I can't speak enough about the integration of our peer recovery specialists. So having our peers available to work with our patients, not just those with substance use disorders, but our patients that are coming in with dual diagnosis, that have navigated the challenges of the system themselves. They're able to connect with those patients and engage them in treatment and build that relationship so that a patient can have the confidence to be successful. Our peers will then see them once they leave the emergency department and continue to collaborate. And that is extremely helpful for our patients and the patients' families as they go on their journey for recovery.
Yeah. Dr. Del Fabbro, were you going to add? Mm-hmm.
I think just reiterating what Lisa said, having a team is key. I don't think this can be done just having a psychiatrist or just having an NP. It's the whole team. Having the social workers has been instrumental. Having a tech, everybody has a different point of view and everybody is able to reach the patients in a different way. Peer support, we're trying to get a peer support person on our team. They're hard to come by, but I would love that. And a pharmacy tech. Those are the two of my wants. But just the team approach, and then also the collegiality with the ED. And you have to have buy-in, obviously, you know, from administration and from leadership. I think Bill Wasserman and Dr. Trestman have been really wonderful in allowing us to do this work, and I am so grateful to them.
Wonderful. So Lisa, I am so glad that you touched upon the peers, because I was going to ask specifically about that. You know, the peers conversation and the integration of them within behavioral health treatment has been a conversation and a goal of many for multiple years. And I've personally seen, you know, firsthand how that connection with someone who's gone through a similar, you know, challenge as a family member has been helpful. And so if you could encourage other organizations to incorporate peers into their programs, what would you say? How would you address some of the concerns that folks may have around utilizing peers and some of the challenges that folks may, you know, think that they may encounter if they were to bring peers on? Can you just speak to that for a little bit?
Sure. I think you have challenges with staffing across the board, right? Folks have different things happen, and we manage that to the best of our ability. Our peers have really been key on our inpatient unit, on our medical settings, and our emergency department to meet patients where they are. So they have the resources and the lived experience to really share, help explain, offset some of the fear that our patients are experiencing, and also help our patients navigate some of the stigma that they see when they come into our system to receive care. We on our inpatient units have sent our nurses and psych techs, those that have lived experience and are working in our inpatient unit, through the peer training as well, so that they can have that deeper understanding and connection with our patients. I can't speak enough about having peers and the wonderful work that they do, and their ability to really meet the patient and connect with them. They help the patients navigate the complexity of healthcare. They can get things into their language so they can understand really what we as the treatment team are talking about, and help them see things through a different lens. Not only do they help the patients, but they help our team. So they come in and explain things from the patient's perspective of, how we may have approached the patient or approached a situation, so that we can look at things differently and be more patient-centered in our approaches when folks are coming in to receive services.
Absolutely. It's such a core part of the treatment, and as you mentioned, the recovery journey and all of that. And so it's really exciting to know that you all have really integrated the utilization of peers, and hopefully Dr. Del Fabbro will be able to address the issue with being able to get them, employed within the hospitals. I know that the state has been working very hard in terms of reimbursement for peers and ensuring that they're getting, a fair wage in the work that they're doing, because it is so critical and so important. So are there any last words or any advice that you want to pass on to your colleagues as they think about instituting some level of emergency care for individuals within their system?
I think just creating a team and just taking away the stigma of mental health are two of the things that I think are very important. And of course, anybody can reach out to Lisa or myself if they need any, boots on the ground advice. I think peers, again, with the peer support, if we can help anybody institute that, it would be fantastic. So I would just say get your team and get buy-in from the higher ups.
And I would add, relationship building. So the relationship with your community partners that are, coming in to see patients in the ED, the collaboration with your ED partners, and then really trying to shift, our culture and some of our practice to be that of more trauma informed, so that it's not so traumatizing for folks coming into an emergency department to receive services for their illness.
Well, thank you all so much, and thank you for stepping up and taking the lead on a program such as this. You guys were a little bit before your time as it relates to everything that's happening now, so I'm glad that Carilion was able to get the program up and running in the time that they did. And once again, I would like to thank Commissioner Smith for his words, and you, our audience, for joining us. If you have any follow-up questions, please direct them to my colleague, Julian Walker at jtwalker@vhha.com. That is jtwalker@vhha.com. And please join us for the next webinar in this series, which will take place on Thursday, December 8th at 12:00 p.m. And we will feature the new Behavioral Health Children's Pavilion at CHKD. Thank you and be well.